All right, good afternoon. It is just afternoon on March 1st, 2022. I'm Dr. Deuk. We are at the Deuk Spine Institute and Surgery Center Viera. We're getting ready to start our second surgery of the day. This is a live stream of a lower back. We're fixing a patient's back pain. This patient has 2 herniated discs with annular tears and inflammation. We're going to first numb him up. He is awake for the beginning, as all of our lumbar patients are. I'm going to give you a little injection, okay? You'll feel a little stick and burn. Now, I don't know exactly where my entry point is going to be just yet, because I have to sort of get the x-ray in, I have to get the needle in, and before I put the needle in, I want to numb him up. So I'm going to create a wide field of numbing medicine. My anesthesiologist is helping me make the patient comfortable while we inject local. I did 6 cc's of local. Watch out for the needle there. All right, so the first step, and we're on the right side because the disc herniations are worse on the right. And I think he has radicular symptoms or findings worse on the right. So we're going to go in on the right side and let me know if it's hurting you too much, okay? Just don't move around. I feel like I'm a little low. Yep. A little bit low, so we're going to need to start a little higher, but I've infiltrated this area as well. All right, shot. As far as your entry point, you want to be as low as you can be, but you have to get above the iliac crest. That's the key. Shot. So, and you just have to keep moving north until you find a spot. Oh. I'm aiming for that L5-S1 disc. Shot? Are you comfortable?
You said yes, Jimmy?
Yeah, you said yes. Shot? Shot? So the first thing I'm going to encounter is his facet joint at L5-S1. And I can tell you, he has really enlarged facets right there. I don't know if you can see just where the needle tip is. It's very dark and big compared to the one above. Show us the one above. The one above is called L4-5. That's a little lower. The facet, yeah, right there. And then the one above that, the L3-4, is even more normal. Yeah, right there. Go put the arrow in the center of the facet. To the right. Up. To the right. Right, right. Stop. That's a more normal facet. Now compare that to where we are right now. You can see where we are right now is very dark and thick. It's sclerotic. That means there's a lot of arthritis going on in those joints. All right, now I've got to get around this facet joint. Shot. And that's easier said than done. Our patient has a nice anatomy so far, but I still am going to have to navigate. Shot. And the navigation to 5-1 is the hardest. Shot. So I keep encountering that facet joint. I'm going to have to redirect. Shot. I'm going to have to make it a steeper approach. You're fine. Shot. 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 Where do you feel the pain?
Where's in your back, Johnny?
Shot. All right. The back is okay. We can live with the back. We just want to make sure there's no leg pain. Shot. All right. I need an AP. Are you comfy?
I'm sorry, say it again?
Are you comfortable?
I said yes.
How's he doing?
Good.
Stable?
He is stable. It's sometimes hard to hear with the mask. He has a mask on. We use the mask. So I'm translating.
The oxygen mask.
Oh, yeah.
I thought you meant a face mask.
I don't use nasal cans. I'm a good anesthesiologist.
Yeah, you want to monitor the end tidal CO2.
I can't give it to the regular face mask.
Huh?
I can't give it to this face mask.
I know, that's what I was going to say. You don't have a regular face mask that You see these people driving around in their car with face masks on.
We have a packing nurse in Las Vegas who puts the oxygen on and then puts the face mask over. I said, don't ever do that to my
Yeah, yeah. All right, so on the AP and lateral, we're looking good. I'm looking at the pedicle of L5, and Jordan has got it lined up beautifully. I'm just looking at that L5-S1 disc space, and it looks terrible. It is so badly damaged. You can see it's just horrible. It's gotten worse, I think, since your last MRI, Yannick. So, all right. We'll get there. Any pain? Sean? Oh, all right. He's a tough guy.
He said not really.
So we're right at L5-S1. And let me see. Sean? I'm bouncing up against like a bone spur here. But you can see we're lined up pretty good. So this may be one of those where we have to put him to sleep to get in. I don't know yet. I'm going to try a little bit more to see if I can get into the disc space, but it is extremely collapsed. Sean? Huh? Yeah, I'm right on the end plate of S1. You're fine. We're below the nerve root. So it's unfortunately just a very collapsed disc space. Shot? Yeah. AP. So I may have to have you try to clean up S1. I think there's some scoliosis because the L5 pedicle is lined up beautifully, but the it's really hard to see that disc. Yeah, we're right where we need to be. I'm really happy with the AP. You can see the pedicle of L5. You can see the pedicle of S1. We're exactly where the disc is. So, like I said, this patient's, if you look at his MRI, when was the MRI done? So in September, so that's 5 months ago, almost 6 months ago. That's how old the MRI is. Normally 6 months you don't see this much damage occurring as a result of waiting, but definitely there's a change. Sean? Yeah. I just cannot advance the needle. The disc space is pretty collapsed. So let's get one more AP view. I think Luis called it. Luis told me that we're going to have to do L4-5 first. Yeah, we're right there. We're literally up against the end plate of the sacrum. You can see it. So I'm trying to go above it and into the disc, but it's not wanting to go. So at least we're in a safe position to put the guide wire and then do advance the dilator once he's more asleep. So I guess we're just going to have to live with that. Okay. Next, we're going to make our incision. And this is a 7mm incision. Just big enough to get our tube down. So just to give you an idea, how big is the tube? This is the tube. The entire surgery is done through this tubular retractor. Are you comfy? Patient's going to be awake for this part so that he can help me navigate, Sean, around the nerve roots. We want to make sure we don't get too close to any of the nerve roots. The nerve roots are what comes out of the holes in the spine. And we don't want to touch the nerve roots. We don't want to get too close. Are you comfy?
You doing okay?
You all right?
Yeah, he says okay.
Good. You're doing great, by the way. Everything's going well. Sean? So we're heading right towards L4-5. We've got the pedicle of 4 and 5 lined up beautifully. We're literally at the tip of the needle is literally at the facet joint between the superior articular process of 5 and the inferior articular process of 4. So we're just going past that facet joint right into the foramen, right below the exiting nerve root. And we're lateral to the traversing root. I can feel the herniation. Literally, look at this, I'm bouncing on it. I'm bouncing on it. I'm getting resistance from the herniation. Are you comfortable? All right, let's get an AP. So we're going to need the patient awake to do our discogram. All right, so in the AP view, we're right at the mid-pedicular line. We're exactly where we're supposed to be. So I use two views, AP, which is front, back, and lateral, to make sure that I navigate to exactly where the herniation is and the tear begins. So we're going to enter the disc in a damaged part of the disc so we don't create more damage. And that damaged part of the disc happens to be the part of the disc we're here to fix. So, all right. I feel like taking one more stab at 5-1. I hate, I know, but it's such a tight little space that if I back out and I try to go back again, I might miss the target. So I don't want to lose what I have. It's really hard to see the back of L5. Let's see first if we can get the fluoro adjusted at 5-1 a little bit better. I think that's a little worse. Yeah. You know what? I mean, that's better. That's probably as good as you're going to get it, Jordan. No, I'd go back to where you were. I think that where you had it was the best. Right there. Maybe a little bit more. Yeah, it's pretty darn close. I mean, there's just so much arthritis. Show them the arthritis at that 5-1 space. Look at the bone spur in the front. Just follow the bone spur in the front. Yep, right there. Look at that beak. That is totally abnormal. And now show them the disc space at L4-5. Look at the disc space here. Look at how well defined it is relative to the end plates of the bone. You can tell the difference between the bone and the disc nicely. But then go down to 5-1. Look at how it blurs. You can't really tell the difference. That's worse since I last saw him, much worse. And he's having a lot of pain in his lower back, and that's worse because of something called inflammation. That's just inflammation in the disc. All right, well, I'm not gonna be able to get a better needle trajectory, I don't think. And I really don't want to lose what I have. So I'm gonna basically put the guide wire down at 5-1, bring the dilator down, and I'm gonna just advance it into the disc space when he's asleep, so he's not tightening up his muscles. His muscles feel pretty good, but he's a very muscular guy. Are you awake? Yeah, he's very fit, very muscular. What happens is when patients are awake, they feel pain and they tighten their muscles, and that squeezes the bones down. It makes it harder for me to get in. So I'm going to start with 4-5. We're going to do our discogram and just see what the situation is at L4-5. So normally I'll test all the discs with a discogram. The L5-S1 disc is right here. I'm just drawing it on the skin, but it's actually deep inside. And then the L4-5 disc is right around here. Now he has a tear from, you can see it on the MRI, and in this tear of the annulus at 4-5 and 5-1, you can see the jelly has pushed through the tear and is sticking out. We call it a herniation, and that's where his pain's coming from. And so this is L4-5. And this is L5-S1. We're going to test L4-5. I can't test L5-S1 because we're not in the disc. We're right at the entrance. Are you comfortable?
He said yes.
All right. How bad is that on a scale of 1 to 10?
0 to 10.
You hear that?
10, 10.
10. Is that where you get your pain? I told you we'd find it. Relax. Look how he tightened up. His muscles are like a washboard. You're going to go to sleep now. So, as I said, we could only test the one disc, and it is definitely causing his pain. 10 out of 10. So let's write that. So L4-5 is 10 over 10 and concordant. I'm sorry. I'm very sorry. We're going to put you to sleep, and when you wake up, that pain will be gone. All right. Count from 1 to 100 out loud in French. C'est français. 2. Not bad. He got 1.5. He got a and a duh. All right. Never made it to 3. So he's nice and sleepy now. We're going to get started. And again, I'm starting with the L4-5 first because the L5-S1 really collapsed, really going to be difficult to get in, and I need him way asleep. And I got to give my anesthesiologist a chance to get him like deep enough asleep. So every patient requires a different amount of anesthesia. The anesthesia is propofol. It's measured, it's a liquid, so it's measured in milliliters per minute. And literally every patient has a different milliliters per minute dose that needs to be administered to maintain anesthesia. So my anesthesiologist needs some time to learn about this patient and figure out what his milliliter per minute dose is. And it takes 5 to 10 minutes to figure that out. So I got to give my anesthesiologist some time before I go for the difficult disc. Okay, is that our shot? Yeah. All right, good. So I'm leaving the guide wire, taking the needle out. Shot. You can see the herniation in the back. Show them the herniation. The black thing behind the disc. That is correct, right there. It's pretty big. And that's the nerve root that the herniation's hitting. Very good. All right, so we've already made our 7 millimeter incision. Remember, this is arthroscopic surgery. We're going to use a dilator next. So this poor man has been suffering with back pain for how long? All right, so you see that? He's having a little bit of discomfort. He's letting us know. My anesthesiologist is responding by giving more of the sleepy medicine. So I'll just wait a minute for that to work. Is that our latest picture?
Yes, sir.
All right. So Rita, the next patient has a device. The nurse was concerned about magnetic fields. We don't do any magnetic fields. This is just X-ray. Do I need to be concerned about that? All right. All right, so now that the patient's a little more asleep, we've increased the dose of anesthetic to make him more comfortable and sleepy. We can advance all the way down to the disc. Now I'm going to go just past the nerve. Yeah, and this is that painful area. Why is that so painful? Inflammation. Look at the inflammation has destroyed the bottom disc. We don't want that inflammation to destroy the L4-5 disc. It will if we don't treat this. Shot? So by doing this procedure, I think we're going to be able to stop the inflammation from getting worse. God, look at the dilator. It's literally just going through the tear without even a hammer. I don't even have to hammer it in. It's just going. And I can push even a little bit, and it's going to advance. So the tear is pretty big. So I don't like to move things a lot. I like to move them slowly. No, we're in. Shot. Shot. Wow, there's so much inflammation. His disc is pushing the dilator out. All right, so we're inside the disc with the dilator. Now I'm going to bring the tube down over the dilator, and we're going to do the whole surgery through this tube. So I have to advance the tube. And I know this looks brutal, but the safest way to do this is with a special surgical hammer. And a lot of people don't understand the value of a hammer in surgery, but it allows the delivery of a very controlled amount of energy by the surgeon. Shot. All right, we're in perfect position inside that disc. So I've passed through the tear. So remember, he has a tear in his disc. That's where the herniation came out. I've literally gone right through the door that's already open with this tube. We know this disc is causing his pain. We just tested it with the discogram. And he had 10 out of 10 pain that was concordant. So I feel really good. Even if we fix this one disc, we'll get rid of at least 50% of his pain. All right. We're going to bring the scope in next. Thank you, Luis. All right, here we go. Irrigation on. We use irrigation quite a bit. Irrigation is saline, sterile saline. Everything is sterile. Grabber. Okay, there's the bottom of the tube, and there's the disc. So, see if we can get any of these herniation fragments. A lot of times when we put the tube in, we're pushing the herniations into the disc. I like that. That's Dr. Anthony Young taught me this technique. It's called the inside out technique for endoscopic disc surgery in the lumbar spine. And it's basically where you're starting inside the disc, working your way out. It's safer that way. There are other endoscopic surgeons that start outside the disc and work their way in. But I believe in the inside out technique that Dr. Anthony Young pioneered. You gotta grab that pedal for me, my friend. All right, you're seeing the laser fiber. I think we're a little bit overexposed. Careful with that sterile field on the fluoro. I would move the fluoro. Yeah, move the fluoro out. And then actually maybe the anesthesiologist can push the right button. All right, that may work. That's good, right there. I wouldn't go any lower. That's perfect. Thank you. We had to bring the light intensity down because it was a little bit overexposed. Okay. Yeah, after all, you're dealing with a camera, right? I mean, that's what's projecting the endoscopic image up to the television monitor is a camera. So we're inside that tear, inside that bad disc at 4-5, and I see a lot of damage from inflammation. Is this still the 54 joules?
Yes. Or they use
Yeah.
watts.
54 watts, sorry. Yeah, it works really good. It's very efficient. This is scar tissue. Calcification over here. You can see the annular tear right there, the blue thing. Got to work it from both sides. Any questions from our audience so far?
No, sir.
All right. Some of you don't know, but we have an entire team here in the operating room. It may seem like it's just the surgeon and the anesthesiologist at times, but we have a large group of people. They're here doing different jobs. One of them, for example, is our nurse circulator, and she's doing a lot, but mostly helping the anesthesiologist make sure the patient stays safe, and managing some of the equipment in the operating room, for example, the endoscope, and turning it on and off. That's also Jordan, our x-ray tech, who helps out. Managing the irrigation. Irrigation is liquid. You can see it in the view right now. It's what's kind of moving everything around. Even if I turn the laser off, you can still see the movement of tissue. That's fluid moving through. It's nice cooling fluid. Our irrigation is chilled in the refrigerator. It keeps the laser cool. It keeps the tissues cool, so we don't get burning of the tissue. If we didn't have this liquid here, the tissues would be burning. They would literally turn into charcoal. And we don't want that. That's not good for the patient. So, oh, look at that. All we're interested in is really vaporizing the bad tissue, but not creating char. All right. Anybody know how long this patient's had back pain? From the H&P? Because I don't remember. I know it's been for years. I can see this right here is all, it looks like crystals, but it's actually calcium. 5+, that's all it says? Yeah, it's been long. A lot of our patients come to us with a history of pain for 20 years, 30 years, but it gets bad in the last few years, and then they come in and get it fixed. Unfortunately, waiting to get your disc pain fixed is not a good idea. I don't recommend it. A lot of doctors don't know this, but the reason people have back pain is from inflammation. And inflammation is a destructive process. We see that right here in this tear. It's destroyed so much of the disc, especially the L5-S1 disc. That disc at L5-S1 looked a lot better on the MRI scan, you know, just 5-6 months ago. And now it looks worse. Just waiting for the surgery was just, oh, look at that pink tissue right there. You see that? See that pink stuff right by the laser? That is granulation tissue from inflammation. That's what's causing his pain. His pain comes from that area. So I got to make sure I obliterate those pain fibers. And the reason is this chronic inflammation within the disc creates an ingrowth of new scar tissue, which is called granulation tissue. And it's very pink because it's got capillaries that you can see through, and they contain blood vessels, microscopic blood vessels, but it looks pinkish to the eye, unaided eye. And there's also nerves, pain nerves in there that are non-myelinated, so they're very easy to activate. And we know that the pain nerves here are all from the somatic afferent variety, which means that those pain fibers take pain signals up to the part of the brain that is located in the sensory homunculus. And the sensory homunculus is that really topographically oriented area of the brain. In particular, this would be the parietal lobe. Okay, parietal lobe. And specifically an area of the parietal lobe called the postcentral gyrus. And that postcentral gyrus part of the brain, and it's on the opposite side, by the way, of the brain, it would basically relate these pain signals from this area of the disc to the back, to the lower back. And that's how you get lower back pain. That's how the brain perceives lower back pain, is by the synapsing of, there's more pink, see it? You see that, Kevin? Pink color?
Yes,
in the
sir.
tear?
Yes,
That's
sir.
where the pain fibers are. So by debriding this tear, we're getting rid of this tissue that's painful. You hear him right now. He's like, ah. So he's a little lighter. We'll put him down, but this is a painful area, and that's what we're getting rid of that pain source. Do you have any questions from the audience?
No, sir.
Yeah, I've never seen an audience who knows everything. By the way, folks, don't feel bad asking questions. I'm able to operate and answer questions at the same time. At this point, it's kind of like your teenager playing video games, you know? They can actually carry on a conversation with you while they're playing video games. Maybe even some of them will convince you they can do their household chores while they're playing their video games. But yeah, this is like Tetris right here, you know? And I can talk to you and answer questions. So don't feel like asking questions is gonna interfere at all with the surgery. I won't let it. And if I can't answer it, I'll just say I can't answer it. Yeah, all right, you're doing great. We're in that painful area. So everything's okay. How are we doing on irrigation? Good? All right. Thank you. So I got to wiggle things around a little bit, but this is all that painful area of the disc. This is the tear, the annular tear that we talk about. Hey, Kevin, show the audience the annular tear video and how annular tears and disc herniations together cause back pain.
Yes, sir.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.
Done with this disc. Why don't we show the audience how the Deuk laser disc repair works to get rid of the pain? Okay, can you do that?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
At this level, I'm just putting on my finishing touches, and a lot of scar tissue. This patient has some type of an inflammatory condition. I don't know what it is exactly, but I'm just looking at all this. This is all scar tissue here. So it's very common for me to find scar tissue inside the disc, like all this stuff. This is years and years and years of inflammation going on in the disc, causing that back pain. So I feel really good about it. This is a little bit of epidural fat. And that's it. I mean, I think we're pretty much done. All right. We're going to try to get to the next disc at L5-S1. I'm just sucking all the juice out. Scope off. Good. All right, little antiseptic. And we always use antiseptic because, quite frankly, we don't want to get an infection. We have never had an infection here in the spine with the Deuk laser disc repair. I've done now 1,400 plus surgeries, and probably going to be 1,500, by another few more months. And in 1,500 surgeries, we've never had an infection. So the reason is there's no bleeding, there's a minimal incision, and so it's very hard to infect a small space like this. We also use antibiotics, which are pretty standard in surgery, to use antibiotics for surgery. Okay, we're done with that disc. Now we're going to go on to the next disc. I'll apply a little bit of pressure just to make sure we don't have any muscle bleeding, which is vein bleeding. On 310, March 10th. 2:15, 2 to 2:30. Yeah, 2 to 2:30. So on 310, which is what, Thursday? Yeah. All right, so basically what we're talking about is I've been invited to speak on the Deuk laser disc repair procedure to neuroscientists from around the world and leaders in the United States at an annual meeting called the Society for Brain Mapping and Therapeutics. And they've taken a particular interest. They have a spine section, and they have a particular interest in advances in spine surgery, like the latest, greatest technologies. And of course, the Deuk laser disc repair is that. And they have invited me to come and speak. So I won't be able to actually travel there because I'm going to be in Italy on March 10th at my son's first test with Van Amersfoort Racing at Misano. So I'm going to have to give my talk virtually, like many of the other doctors will. But it's on March 10th at 2 to 2:30, basically. From 2 to 2:30, I'll be speaking on cervical Deuk laser disc repair and thoracic. That's 2 to 2:30 Pacific Standard Time, right? California time is Pacific Standard Time. So if you want to watch, you're welcome to. Maybe you have to, of course, join the meeting. All right, so this is not going to be an easy one. I think we need to zoom in a little bit more so I can see things a little clearer. Give me a full zoom, and that's better. I may try to get in there. I may try one more time. Let's have a needle. Yeah. No, I want another one. I'm just going to try one more time. And I'm going to stay in a safe area, so we'll be good. Sometimes you never know, you might get lucky, and I think I could be a little bit more north and have a better shot. It's too north. It's too medial. I need to be a little more shot, a little more lateral. Shot. It's just really directing me north. Shot. Shot. That's what I'm talking about right there. Shot. Yeah. Yes. That is definitely a better trajectory. Shot. Oh yeah. If I could just make this work. Give me an AP. So I'm trying to get a little bit more north, a little higher towards the head, a little bit up. I know it's hard to orient, but I think if I'm a little bit more like that, I might be able to get into the disc. So, all right, so we're still too lateral. Yep, that's good. So I'm going to need to stay up north. Interesting. So I'm more lateral. I need to be a little bit more medial. Shot. Shot. Let's see where we are on the AP. I think we're off on orbit by a degree. We need to fix the orbit. You see the back of the vertebral body of 5 at the bottom? It's off by a degree or two. Shot. Yeah. That first needle looks really good. It's just a little bit low, and I can accommodate for that by, you can see the facet joint to just a little bit proximal on the tip of the needle, right where the other needle is, as a matter of fact. It's kind of pointy there. That's all bone spur. Give me that shot. I'm waiting for you. All right. So let's fix the orbital issue. I don't know if that's any better. Try the other way. All right, try a little bit more. Now, I think, what do you think? That looks worse, right? I think that's more realistic. And I'm still far away on the lateral. Shot. That looks good on the lateral. Let's see what the AP looks like. Do you think he's responsive enough? Or is he pretty snowed out? All right, well, I'm pretty low. I think we're okay. We're clear from the nerve root. Let me just see what my AP looks like. Yeah, AP doesn't look too bad, actually.
Give me like 5 minutes, I think you're ready to go for that.
Let me just see what I'm thinking here. I mean, we're well below the exiting route.
How are you? Yanni? Yanni? You okay? Can you give me a thumbs up? Thumbs up? Okay, good. Yep.
Ask him if he's having any pain.
Yanni, are you having pain down your leg? Any pain anywhere? Yanni? Yes or no? Yanni? No? Or yes?
We're asking the patient. Are you letting it wear off?
Yeah. Oh yeah.
All right, so I don't mind waiting a few more minutes.
I got everything off there.
Yeah, let's just give him another couple of minutes to wake up a little more, and then you'll have to put him down again, but at least you have a good idea of where he needs to be, you know, and your rate. You're using the infuser, right?
Oh yeah.
Mm-hmm.
That's really the only way to go with this.
Yeah. I would just feel better knowing that he's awake and that we can navigate here safely.
Yanni? Are you having pain down your leg? Yanni?
Any pain?
Pain down your leg, yes or no?
Any pain?
He said no.
All right, let me play with it. See, any pain?
Pain, Yanni? Yeah.
Where?
Yeah.
Where?
Pain. Back? Or in your leg? He said in the back. He's feeling
The back.
Yeah. Leg.
Okay, all right.
Leg.
All right, all the way down?
Is it going all the way down your leg? Where in your leg? Right leg? All the way down? Where in your leg?
It shouldn't be anymore. I moved it, but he's reliable?
He is comfortable with it, yeah.
All right, if I can just,
Where are you feeling that, Johnny?
Sean,
Where are you feeling this? What?
he's,
Your leg?
he's probably not feeling anything right now because I'm not even near the foramen. I'm just trying to get my angle a little bit better. Sean? 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 All right, so let's do an AP, see where we are. So for those of you watching and interested, I'm trying to get this. This is the hardest part of the surgery, is honestly getting the navigational part done properly. All right, so we're at the lateral border of the pedicle. I don't know what you're doing there, Jordan. We're right at the lateral border of the pedicle, and on the lateral view, it looked pretty good. So let's go back to the lateral view. Are you comfortable?
Johnny, any pain? Johnny? He said no pain.
All right, tell him to lay still. Everything's going well.
Everything's going well.
I just need him awake for another few minutes, that's
We're
all.
gonna put you off to a deep sleep, Johnny. Okay? You're gonna tell us how you're doing. We ask you, all right?
Sean, we're so close. Anything?
You have pain down your leg? Or your back?
Probably his back.
Where's your pain? Huh? Back?
In the back? I think it's his back.
Yeah. Right back.
Sean, AP, I think we're starting to go into the disc. This is clearly a bad disc for him.
Yep.
Just relax. Yeah, we don't even need the discogram. Where is he having it?
Where is your pain? Back? Where is it? Left?
I need to know if it's back or leg.
Is it back or leg? What? Say back or leg? Leg or back? Tell me where.
There's
Back. Back.
Sean. I don't know if this is just a lot of calcium here. Relax, you're doing okay. Everything's fine. Sean? Sean? Jordan, I really think we're off somehow on orbit. Let's try to fix the orbit. Let's do a few orbital shots and see where we are. I'm not sure. Yeah, it's really hard. We're looking straight down the facet. Huh? Shot. Shot. Yannick, just bear with me. I know it's uncomfortable, but this is the most important part of your surgery right now. Shot. Are you okay? Shot. 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 Still awake, right?
Hey, Yannick, are you with us? Where is your pain, back or leg?
He probably doesn't have much right now. I mean, to me, that looks like it's a great trajectory. Where?
Where, Yannick, you said? Where? Back? I say it again.
Deuk laser.
Back or leg? Back?
Wow, his disc is it's got a lot of calcium. I've never seen this. This is really unusual. Shot? To have this much, huh? Yeah, it looks like, almost like HLA-B27 kind of stuff.
But can you only have it in one location? Usually it's throughout the whole, right?
That's insane.
It's not one disc.
It's almost like he's auto-fusing. All right. Sorry.
So you know what I think this is related to? Like the motorcycles.
I don't know.
Right?
I don't know. I could be.
Could be a
Let's get a shot. Let's just see what it just shot. Shot. Okay, all right. He said left.
Yeah, he says a leg.
Okay, Yannick.
Give him some medicine here.
No. Just keep him. I need him awake.
Okay.
I need to make sure. Give me an AP.
So you're looking for some type of extrapolation.
Yeah. Is that better? Ask him if he's better.
Hey, Yannick, are you better?
Yeah, so there the dye was leaking out. And leaking out, and look at it affecting his nerve root, irritating the nerve root. So, yeah, it's just tracking along.
So that's why he's saying leg.
Yeah, it's tracking along. Well, I know the other needle is in good position. It's not close to the root. So the question is, can I proceed and just angle it into the disc? You okay?
Yannick, you okay? Yannick. He said yeah.
All right, you haven't given him any more medicine, right? Yeah. The anatomy is just so distorted with all that bony change.
You could just give it a little bit off that lip, right? A little bit.
Yeah, I'm not worried about that, because what we'll do is we'll take the guide wire, I'll bring the tip of the dilator right down to the back of the disc, and then I can angle it up and go into the disc as long as he's asleep. I'm just amazed at how much inflammation there is and how much more destruction there is. Since his MRI. Why don't you give me the WAG? I just feel like we're not really seeing that space as good as we can, but I don't know if it's just obliterated from inflammation. Shot? Shot? What's that?
The second needle you put in, you felt was a little higher up in the frame and a little too high up.
No, the second needle's not too high in the foramen. I just couldn't get a discogram, and I felt resistance like bone. So I'm wondering if that thing is infusing. Clearly he has pain there. Are you okay?
Hey, how you doing? You all right? Any pain? Got it?
Go ahead and run the comparison video while we're figuring out what we're going to do here.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself, whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement, whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica,
All right,
and
Dr. Dumajian, we're back after you've watched the video. We have L5-S1 is a problem. There's been so much destruction of the disc over time, and it's gotten far worse than the MRI that was done roughly 6 months ago, that the inflammation can sometimes be so severe that it causes bone to form inside the disc and can even fuse the bones together. It's very rare, but it does happen. And I have been trying to access this bottom disc. We've already fixed the L4-5 disc. That was causing 10 out of 10 pain. I've placed a second needle at L5-S1. It's cleared the nerve root. He's not having any leg symptoms, and I just need to figure out which of these I'm going to use to try to get into L5-S1. On top of that, things are a little difficult because not only is the L5-S1 disc so collapsed and tight, and bone spurs and bone and scar tissue, but also the facet joints in the back are huge. They're enlarged from arthritis in the joints. It's made it harder to get in. And then he has a degree of what's called congenital stenosis, or narrowing from short pedicles of L5 and S1. Are you ready? So we're going to make an attempt to access L5-S1. I'm going to use my newer access point, which is a little bit higher up than the other one. But both of them are feeling the same to me. I'm just feeling bone. Once I get into the disc, I'm entering the disc and I'm literally encountering bone. And I really think that his disc is fusing itself. And if that's the case, there's nothing I can do to stop that from happening. Are you asking what? Oh, it doesn't hurt up here. The pain is all down by the disc. If the problem is if I numb his disc up, then I numb the nerve root up. And I don't want to numb his nerve root up. Shot? Yeah, all of his pain will be further down. So I'm holding my guide wire as I advance my dilator down. And I feel really good about clearing the nerve root because we're well below it. And I placed that needle and guide wire while he was awake, and he had no leg pain. He had leg pain at one point when I injected dye into the disc, and it actually came back and hit the nerve root and caused leg pain. And you can see it track around the root. But right now, he seems to be comfortable. And so far, I'm bringing the dilator down. There's a lot of compression on the dilator, meaning it's getting tight as we're at the back of that disc. Let's get an AP. So we're really doing everything we can to fix L5-S1. And I'm just wanting to see what's going to happen when we get inside that disc. And I won't be surprised if that thing is fusing itself. All right, that looks pretty darn good. We're at the back of the disc. We're clear below the pedicle of 5. L5 pedicle is clearly seen up there above. And that's where the nerve root is. So we're well below the nerve root in Camden's triangle. We should be good here. And I've already tested it with the patient being awake. So I'm going to make an effort to get in here. Let's see what happens. Luis, I don't think I can do it with the guide wire there. Shot. So go ahead and pull the guide wire. No. Hold on. Take this and pull the guide wire. Yeah. Shot. So you can see we're in perfect position for that disc. And let's see. It's hard. You hear that? That's I think that disc is fused since we last saw him. I mean, that's incredible. That just shows you the degree of inflammation. That's, yeah. All right, let's go take a look. I think this is going to be a long run for a short slide on this disc. We can take this out at this point. We don't need it. We're going to go take a peek with our tube, but I'm getting tremendous resistance. I can't put this in any further. There's basically bone inside the disc space, as I suspected. So I'm going to go in with the tube and take a peek with our endoscope since we're already here. I have a feeling we're just going to see bone. So basically his disc has fused itself since we saw him originally with his MRI, and there's nothing we can do as doctors to prevent that. That's just severe inflammation. Very interesting. You can see the inflammation on his MRI scan. But yeah, we rarely encounter a disc that fuses itself from severe inflammation. Okay. Scope on. Yeah. That is just bone and soft tissues. It won't even go into the disc. There is nothing we can do. So, unfortunately, this disc is fused. I don't think it's going to be causing him pain, which is the good news, because once you fuse a disc, the pain usually goes away. So in doing the surgery for how many years now? I think 18 years. Is that what I've been doing this surgery for? I think I've seen 2 or 3 discs at most that have fused. So yeah, it's rare, very rare. Huh? So L5-S1, attempted DLDR, disc auto fused. But wow, I mean, think about how much inflammation has to be going on in that disc space to cause the bones to fuse together. That's incredible. We talk about disc disease as being inflammatory, but typically we can get to the discs before they fuse themselves. L4-5 clearly wasn't fused. We were able to fix that one, but L5-S1 has fused itself. All right, hold that down. Good job, everyone. A bit of a surprise, but nonetheless, I think we've gotten his pain source, and he'll be happy once he's all healed up. Any questions from the audience?
No, sir.
All right, good job, everyone. I need a pen, and I'll be over there to answer questions. Dr. Deuk here at Deuk Spine Institute. It's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had 0 pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L4-5, L5-S1, and you can see in this footage right here that we grabbed the herniation out, and it was one of the herniations was really big, and it was really gratifying to get it out because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well, and I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a good diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
I'm Dr. Deuk. It's January 26, 2022, and I'm here with one of my patients who you underwent the Deuk laser disc repair on your lower back for some herniated discs about a week ago.
Yes,
How are you feeling today?
unbelievable. For almost 3 years, I had lower back pain, and it just, it just nags at you, wears you out. And then I came here, and you were the first one. I went to 2 other surgeons, and neither one of them picked up what was wrong with me, even though I had the MRI. And you came in, and you told me exactly what was going on, and you performed the laser surgery, and I'm like a different person.
Yeah.
A week later.
Yeah, you were a different person the next day, right? The day after, you had no pain, remember?
No, absolutely.
Yeah, so that pain's gone for the rest of your life. How does that make you feel?
New life.
Good. And, a long time ago, remember when people did something great, you say, what are you going to do now? They say, I'm going to Disneyland. You already went, I can see.
No, my wife's a big Disneyland fan.
Good for you. All right, so sounds like we helped you with your back pain, and it sounds like you're very satisfied.
Oh yeah, I'm recommending a friend of mine in Connecticut to come here. You have to come here. If you go anywhere else, I really think you're going to be wasting your time. So this guy just looks at you, and he can tell what needs to be done. He's a fantastic talent, and I'm very grateful that I came here.
Well, we're grateful you did too, because it's going to change your life for the better. Congratulations.
Thank you, Doc.
You're welcome. Good morning, I'm Dr. Deuk Machen. I'm here with one of my patients, and you traveled to Deuk Spine Institute here in Florida from where?
New York, Poughkeepsie, New York.
Awesome. And why did you come from New York to Deuk Spine here in Florida?
Because I heard that this was the best place for me to go.
What kind of problems were you having that you needed to come here?
I had lower back problems and numbness in my leg, which was my left leg. This was the best place for me to come.
Okay. So you had back pain, sciatica down your left leg, pain shooting down the left leg.
Yes.
And that was just yesterday, right? When you
yes,
had
that's
that.
correct. Yeah.
And what, do you still have your back pain today?
No more back pain.
It's gone.
Go on.
And is that because we have you doped up on powerful painkillers?
Nope. None
No, it
whatsoever.
isn't. Did anybody in New York offer you spine surgery to fix your back?
Yep. Yes, they did.
Yeah.
And they wanted to fuse it.
Yeah. And you've had surgery before. You had a microdiscectomy, and that helped you for a little while,
Yes.
but the symptoms came back.
Came back.
Yeah. All right. Well, they're not going to come back this time. So what do we do to make your pain go away?
You fixed my back. You did orthoscopic.
That's right. Arthroscopic spine surgery called the Deuk laser disc repair. So leg pain's gone, back pain's gone.
Everything is gone.
You happy?
You did. Very happy.
You're smiling.
Yeah. I'll tell you.
Congratulations.
Thank
Yeah.
you so much.
We did it all through a 7mm incision, just that big. And you can actually watch that video right here, an animation, to see what it looks like to do the Deuk laser disc repair.
A Band-Aid sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own.
So now that your surgery's done, what are you going to do?
I'm going to go home and enjoy my life.
Good for you.
Enjoy my life.
Congratulations.
I'm very happy.
Anything you want to tell your viewers?
Other than this is the place to come, it's worth the travel.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. a Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal. Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair.
Dr. Deuk Machen here at Deuk Spine Institute. It's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy.
How to request a free MRI review. Who are we and what we do? With world-class physicians on staff, the newest and most advanced technology, Deuk Spine Institute has performed thousands of procedures and achieves a 95% success rate in elimination of pain. Treatments? Every patient comes to us with a unique set of challenges. That's why we address every patient's care individually. These are some of the world-class treatment options available at Deuk Spine Institute. Deuk laser disc repair, Deuk spinal fusion, rhizotomy, epidural injection, kyphoplasty, physical therapy. Meet Dr. Deuk, world-renowned board-certified neurosurgeon. Go to www.mri.deukspine.com. Click the Free MRI Review tab on the upper right. Complete the patient information form. Continue to fill out Step 2 of the form. Make sure to submit all your MRI images, plus report. You can submit the MRI through the mail, file upload, or medical record release. You can drag and drop or upload images into the forum. Things to remember when submitting your free MRI review. All MRI images must be submitted along with the report in order for it to be reviewed. Once your case is reviewed by our team, a patient advocate will contact you. Thanks for choosing Deuk Spine Institute.
Operating room and here in front of you to answer your questions and talk about our case that we just finished. So to summarize, this patient had 2 bad discs that were damaged, this one and this one, the bottom 2 in the spine. L4-5, L5-S1, they both had the same problem where they have a damage in the tear in the annulus, which is the ring that holds the center of the disc together, which is the jelly in the middle. This patient had tears, and the jelly had pushed through the tear and was causing inflammation in the disc. And when we got into the bottom disc, lo and behold, I couldn't get the needle in. I kept hitting something hard, and I thought I was hitting the bone here and the bone here, and I kept trying to get in, and every time I tried to get in, I couldn't get in. I just kept hitting bone. And then I realized, and I've had this happen a couple of times, in the last 800 lumbar laser surgeries I've done, it's probably happened twice or 3 times most. I haven't even kept count, that's how rare it is. So it happens about 1 every couple of 100 patients. But basically, the bone here and the bone here have literally fused together, and the disc has calcified so hard, it's become one solid piece of bone. So we call that an auto, because the patient does it themselves, auto fusion. So L5 fused to S1 from the severe inflammation that's been going on in that disc. Maybe had we gotten to it earlier, we would have been able to save it. But because the surgery was delayed for a while, the inflammation keeps going. We can't stop that, and the bones fuse together. So it was a bit of a surprise. I kept trying to put a needle in a different place, in a different trajectory, and I could not get it in. And of course, the reason is because the bones are fused together. So bad news is bones are fused together. I couldn't do that disc, but good news is when bones fuse together, then you don't have pain from that joint. On the other hand, we were able to get into L4-5. The bones have not fused together, and I did a discogram and confirmed that he had tremendous pain at L4-5. So we were able to repair that disc nicely, and I believe he's gonna have no more pain after the surgery. We'll have to wait and see, but that's what I expect. So let's go ahead and take the questions. We have a few questions from the audience.
Will this patient continue to have pain in L5-S1?
Will the patient continue to have pain at L5-S1? I do not believe this patient will continue to have pain. That the bones are fused together. Whenever you fuse a disc, it takes the pain away. So we just didn't know the disc was fused before surgery, because when we saw this patient, it was 5 months ago, and at that time we recommended the surgery based on his MRI showing both discs affected with tears and inflammation. But since that MRI was taken in the last 5 months, the fusion has occurred, and that's why it was a bit of a surprise for us today. We didn't expect to see that. But now that it's fused, there's no movement, and the inflammation will die off, and I think this patient will have no more pain from that disc at L5-S1. So basically we fixed the L4-5, and the L5-S1 fused itself. I don't expect him to have any more pain there.
Second question, when you refer as the bone as being fused, do you mean the disc is gone, disappeared?
Yeah, so the question is, when you referred to the bones as being fused, the L5 and S1 bones are fused. So this bone is fused to this bone. Normally, these bones are not stuck together. They have a joint between them. And just so you can see what I'm talking about, the bones normally are able to move because the disc is a cushion that allows movement, okay? But because the bones are now fused together, they will not move at L5-S1. So what happens here with autofusion is the inflammation going on inside the disc from that tear is so strong and so big, it literally destroys the whole disc, and instead of having a disc, all that disc is replaced by calcium, by fusion matter. So just to be clear, when we surgically fuse these bones together, we take the disc and pack in bone graft, create inflammation by fracturing the end plates with our devices, our scrapers. We get rid of the cartilage and break up the end plates. We create inflammation in that disc space, with surgery, and then over time it fuses. Usually it takes 3 months to 6 months to fuse. So what I'm saying about this patient is his fusion was so strong it literally destroyed the end plates, created a space where it was favorable for his bones to fuse together. His body did that fusion by replacing the disc with calcium carbonate.
Next question is, how long is the recovery time for a patient like this?
How long is the recovery time? So the laser surgery recovery is about an hour. The patient will recover for an hour, then he's going to go back to his home, and I will see him back tomorrow for a checkup. So 1 hour recovery. All right, great questions. I appreciate you all asking them. Bit of an interesting case. Again, if you watch the whole case, you could see that I was trying multiple times to figure out why I couldn't get into the bottom disc, and commenting at the same time about how on the x-ray view, normally when you do an x-ray, you see a space between the bones where the disc is. Because the disc is soft material, the bones are hard, the x-rays don't penetrate the bones as well as they penetrate the disc. So I was looking at that 5-1, and I kept telling Jordan, can you get a better picture? Can you get a better picture? Because what I was looking for was a clear disc space, and we couldn't get one. And the reason is because that disc space was now bone. Not as thick a bone as the vertebral bodies, however, it was clearly on its way to becoming a very solid fusion. And it was already too advanced for me to do anything about. Great case, great for teaching and learning. Yeah, and I think the patient will do fine.